What a pleasure to be here. So shocking things are happening these days. Shocking things like the country's largest outbreak of measles since the disease was essentially eradicated almost 2 decades ago, driven by a steady rise in the number of parents choosing not to vaccinate their children. Shocking things like up to a quarter of patients a week after a myocardial infarction will not be taking their prescribed medications, including meds that could prevent the recurrence of a potentially fatal cardiac event. Shocking things like every day a disproportionately high number of young, poor, Medicaid, and uninsured people of color choose to leave the hospital against medical advice, despite having initially sought treatment for acute and sometimes life-threatening complications and complaints. Shocking things like recent surveys that show that more than half of practicing physicians exhibit signs of burnout, with direct impacts both on their own well-being and on the outcomes for the patients that they serve. These shocking things equate to avoidable suffering, to lives lost prematurely, communities that are fragmented, and overwhelmingly poor health outcomes in the United States, despite the high and rising costs of the healthcare that we deliver. These shocking things, which might on the surface appear unrelated, are connected. Their roots, I believe, emerge from a pervasive lack of trust in the institutions and individuals providing healthcare in this country. Now, trust is a complex and somewhat nebulous concept, in healthcare as it is in the rest of our lives. And in healthcare, as in life, we very easily lose sight of the nebulous and the complex amidst the tangible and concrete pressures of day-to-day. Here's an example. And bearing in mind actually the previous survey, this is a self-selected audience. I'm preaching to the choir here. But I know if I went around the room and instead asked all of you to list the key performance indicators that guide your work, that drive your compensation, that distinguish successful teams in your organizations from failing teams, you would all rattle off a list of measures, many of which we'd find we hold in common. They're revenue, efficiency, readmission rates, hospital days per 1,000 patients, grant funding secured, quality measures, patient satisfaction scores, the list goes on. But I would wager that few, if any of us, would list trust or trustworthiness as a key operating measure in their institution. I'm confident that we all fundamentally agree that trust is central in healthcare. It's central to outcomes, it's central to our roles within the healthcare system. It's, after all, what healthcare is about. Patients place their trust in us. They allow themselves to be vulnerable in our presence in the belief that we will act in their best interests and honor their wishes. This trust is a critical first step in the journey we take as healthcare providers and as leaders. This trust is essential to the physician-patient relationship, to the power that we hold relative to those whom we care for, and to the responsibility we bear as we wield that power. And yet we do not systematically measure it. Until recently, we hardly talked about it. And for a long time, we barely noticed as trust slipped away from us. Hence, the shocking things, and our failure to deliver on the promises of health and well-being for our patients. So why is that? There's something about the nature of trust that has made it so easy to overlook. Trust is subjective, it's deeply personal, and therefore difficult to characterize or to measure. It's influenced by factors that are often well out of our control as clinicians. It's difficult, but not impossible. After all, we've learned to measure and create incentives around similarly complex concepts like pain, depression, anxiety, and satisfaction, albeit not always perfectly and with mixed results. But we've proven that it is possible to harness and take action around such nebulous concepts. With trust, however, instead of digging into this messiness and complexity, for too long we've instead gratefully embraced our inability to wrap our arms around the thing that is so foundational to our roles. And we've done this because it plays into a narrative that we enjoy telling about ourselves. Trust represents the thing that is magical and sacred about our craft, and therefore about us as healers. It's the thing that gives us goosebumps, that elevates us, that makes us feel closer to the divine as we minister to our patients. It's like the sun, we dare not contemplate it, because it might blind us, or confuse us, or stun us with its incoherent brilliance. Because when we focus on trust, we have to ask, as our patient lies before us, naked and exposed, their pain and their fear laid bare in the space between us, their future ours to shape and define, we have to ask, have I earned this person's faith, hope, and belief? Do they come to me willingly or out of fear? What do they expect of me in this relationship? What happens if I'm unworthy of this trust, if I fail them? Focus on trust, and we are obligated to search for the truth beneath each interaction, to listen into the silences, contemplate our no-show patients, reframe our beliefs about our non-compliant ones, own our treatment failures, and in an instant we are humbled, we are vulnerable, and we too become mortal. So instead we look away. We gaze slightly to the left. We wear sunglasses to shade our eyes from the glare. We gaze instead on lazy proxies for trust, which conveniently are scattered throughout everything we do in healthcare. And so we treat trust the way that some of us treat love. We don't measure, track, or question it. It simply is. We reduce it to something basic that's imputed from actions that affirm the thing we already assumed was there. My clinic is overbooked. My emergency room is overflowing. My hospital revenue is going up. My surgical volume has doubled. Therefore, every day these people come to us. They emerge through our doors, offer their chests to our stethoscopes, their arms to our cannulas, their naked bodies to our gowns. Surely that must mean they trust us. And for so long, that's where the conversation has ended. This is why, for the longest time, we did not notice that so many people in need don't come through our doors at all, that so many others hold back parts of their stories from our scrutiny, choose not to share their truths with us, opt against the therapies and prophylaxes that we recommend. We did not notice as others began to infiltrate our space, seized the magic and the mystery of the bonds that we took for granted, sullied them with irritants, with rules, demands, and barriers. We introduced ICD-10 codes, smart forms, prior authorizations, fee schedules, computer screens into the sacred space between us and our patients. And then we built shrines around these interlopers. Huge buildings with sprawling parking lots and maze-like hallways, whole wings full of expensive equipment, the robots, conference rooms and amphitheaters to house top-secret meetings of specialists and subspecialists and sub-subspecialists, long rows of initials emblazoned across our starched white coats so that even our first names were indetectable and obscured. We spent our energy fighting each other, arguing for a bigger slice of the pie, higher wages, more compensation, more procedures, more research dollars, ever larger nameplates, dismissing others, including our patients, who lack our years of training as unqualified. We took for granted the most important thing, the trust of our patients and their families, and instead enshrined the lazy proxies, our power, our status, and the structures that reinforce these. We were so distracted by all this activity that we did not notice as they pulled away from us, and we pulled away from each other. Until more than 700 of our children are infected with measles because their parents do not believe us when we tell them that vaccines are safe and effective. Until patients, birth advocates, and activists take to the media to publicly call us out for perpetrating the racist practices that cost brown and black moms their lives. Until the people whom we have for so long labeled as non-compliant or challenging hold us accountable for ignoring their truths and failing to honor their dignity. Until our constituents begin to vote with their feet, turning to the internet, to social media, to Gwyneth Paltrow, fake news, silence, suffering, premature death, anything but us in order to heal them. Until our colleagues begin to leave the profession, take their own lives, succumb to burnout and depression, now we feel it, the absence of the divine and the loss of that magic. We're finally being forced to confront the truth, which is that it is possible for our profession and the institutions that surround it on the surface to appear to be thriving. Beds are full. Dollars spent on healthcare have grown to more than $3 trillion per year. Entire industries have emerged around the business of healthcare delivery, while at the same time failing to build or sustain trust with the people whom we serve. If we're honest, we all know and understand this paradox. It is possible to don a wedding band, get matching tattoos, produce offspring, and share an address with a person whom you do not love. Because the wedding band and the address are not love. They're convenient, lazy proxies for it. But we invest there, and we gaze upon the proxies, and we think everything is fine, until one day we are confronted by the partner, the lover, the friend who declares, "This is not working. I no longer love you. Perhaps I never did." And we're shocked, we're angry, we're confused, We're lost and we're afraid. We say, look around at all these things, the things I do for you, the things I've built for you, the sacrifices I've made for this. What do you mean you don't love me? Our patients are rejecting our carefully curated superiority and aloofness, our business models built on throughput and efficiency, our coded language and inaccessibility. And they're telling us that they see through our lazy proxies, and that unless we are willing to redefine our relationships, to rebuild them on a sturdy foundation of earned respect and trustworthiness, we will no longer be relevant. When I was a resident, I learned that my job as a primary care doctor would be to see my patients as efficiently as possible, check the boxes in Logician to prove that I had done all the right things, fill out the billing form immediately after the visit, and close my note as quickly as possible. I was a hardworking and dutiful student. I learned to be a great resident, until shocking things started happening to me and my patients. Here's the story of one of these shocking things. I was in my third year of residency, seeing patients in my continuity clinic, a community health center in a low-income but rapidly gentrifying part of Boston, when a lady in her mid-50s popped up on my schedule for a sick visit, chief complaint of cough. She was soft-spoken, well put together in a crisp white button-down shirt and black slacks. I opened her chart and realized that she was a new patient to the practice. She had no problems that we knew of, no medical history, no family history, no medications, no prior test results. And I had 10 minutes to dispense with her single most pressing concern, the cough. Everything else I'd been taught would have to wait until the next visit, the new patient annual physical exam, where I'd be granted the luxury of 20 minutes and a broader menu of checkboxes to guide my visit. But for now, my patient was asking me to do one thing: treat her cough, so that she would not disrupt the Mass on Sunday, during which her new granddaughter would be christened. She would have the honor of holding the infant for 10 minutes, maybe 15, at the front of the church. But the cough, dry, persistent, loud, and irritating, was threatening to ruin the whole thing. So could I please give her something to stop the cough? That's all. Hands folded, head slightly bowed, nicotine stains on her fingernails. Single-word answers to most of my questions, that's all she gave me. Did she smoke? Yes. How much? A pack a day. How long? 25, 35, 40 years? Married? No. Other medical problems? No. Last time she saw a doctor? Maybe 20 years. We continued. I multitasked, typing in the chart, reviewing her vital signs, running through my differential. I examined her briefly, lay my hands on her cool, dry skin as she silently offered up the back of her chest to my stethoscope, looked in her mouth, her ears, traced my fingers up her neck, feeling for lymph nodes and finding none. I settled on a plan: an inhaler, some steroids and antibiotics, an antitussive, and I wrapped up the visit with a finger-waving reminder to her to make an appointment soon for a physical exam so we could do the pap smear, schedule the mammogram and colonoscopy, catch up on immunizations, engaged in the ritualized "thou must quit smoking" exchange, et cetera, et cetera. She promised she would, but I suspected she might not. As I rose to leave, literally with my hand on the door, something, perhaps the fear that she might never return to the clinic, compelled me to do just one more thing. And this is where the shocking thing happened. Instead of turning back around, sitting down again, bringing my face to my patients, looking into her eyes and asking her to trust me with her truth, to tell me the story of her life, to help me understand what had really brought her to my office that day and what had kept her away from the healthcare system for 20 years. Instead of doing all of that, I decided to order a chest x-ray. I sent her downstairs to radiology and kept moving along, saw a few more patients, wrote a few more notes. The x-ray, as it turned out, helped to uncover what I would have discovered had not the shocking thing occurred. It showed an ugly mass in her right middle lobe that would turn out to be lung adenocarcinoma. But its revelation prompted my patient to slowly unbutton her shirt again, remove the bra that she had insisted on keeping on during my earlier brief physical exam, and show me the second cancer, the fungating mass that had been growing out of her right breast for the past several months. This was her chief complaint, the true reason why she had come, and I'd almost let her leave without being seen. My patient seemed relieved, having finally unburdened the weight that she'd been carrying for so long. I was crushed. I realized immediately that I had failed her. And likely so many others before her, yes, I had diagnosed the cancers. Yes, she would go on to receive chemotherapy and surgery and radiation, and actually to do fairly well, all things considered. Yes, I would leave that day having seen dozens of patients, checked all the boxes, closed all the notes. But I had failed to build trust in the moment that it mattered the most. I had lost sight of the most important thing, of sitting, of leaning in, of listening, of seeking and earning the right to hear the truth of my patients' lived realities. The veil fell away from me after that experience. Suddenly, I saw shocking things everywhere, in the terrible outcomes that my poor and marginalized patients experienced, in the language I was learning to use to describe them, non-compliant, challenging, poor historian, and in the misaligned expectations of a system that could reward a physician for efficiency and productivity and yet fail to ask if their patients even trusted them. And equally shocking was the person that I was becoming, as yet another product of a system that was built to serve up lazy proxies for trust, our own power, comfort, and status as healthcare professionals. I became angry and confused. I retreated. I graduated from residency and took a job as a hospitalist because I could not envision practicing primary care in any of the structures readily available to me. I started and quit another master's program. I worked a lot of nights. I debated leaving the country, going back to the United Kingdom where I trained. In the bleary silence of post-call mornings, I often cried as I cycled home from the hospital, feeling acutely the absence of the magic that I so desperately craved. And then, with nothing left to lose, no aspirations for academic success, no letters to add to my white coat, no clear path to follow, I started listening again, allowing myself to be vulnerable. Engaging more authentically with my patients and colleagues, I started seeking and embracing relationships, connections, and the beginnings of trust. And then I found that I started practicing differently, spending less time focused on the nuances of whether I should give 40 milligrams of Lasix or 60, a continuous infusion or multiple IV pushes, less time pursuing obscure and rare academic diagnoses on the margins, and more time seeking to understand how each hospitalization fit into the arc of my patients' lives, how our time together could and would influence their choices and opportunities, those of their families and loved ones. I started leaning into the messy stuff, the difficult patients, folks for whom I'd previously been conditioned to resent, blame, or dismiss. People who didn't take their meds as we told them to. People whose encounters with the healthcare system were marked by choppiness, by abrasion, or anger. I started giving the poor historians the space to tell their stories in the ways that best honored their truths. And in return, they gave me the tools to help actually heal what ailed them. My patients taught me that autonomy, their right to choose and chart their own path, was paramount. They reminded me that they were experts in their own lives. I started calling to check in on my patients after I discharged them, giving them my cell phone to use if they ran into problems between their next PCP visit. Started hosting humongous meetings, family meetings, and goals of care conversations in the lounge, learning the names and faces of my patients' grannies, aunties, daughters, and sons. Those people, the frail and elderly, people with disabilities, folks struggling with serious mental illness and addiction, people experiencing the trauma of marginalization and the violence with which our society treats individuals we consider to be other or less than, those people became my people. And I rediscovered the divine and the magic, ironically in the strange antechamber of the healthcare system that is the hospital. Now we fast forward, here I am, almost a decade later, deep in this next chapter, figuring out how to create from the ground up a healthcare system that is worthy of trust and which is fit for the purpose of truly transforming outcomes for those who need it the most. You'll be unsurprised to hear that the journey begins and ideally is fully contained in the community and not in the hospital. And in my journey as co-founder of Cityblock, I'm learning every day. I'm humbled, I'm vulnerable, determined, and hopeful, and unbelievably honored to be able to share a few insights gleaned along the way. The first of these is that we have to acknowledge and seek to address power inequalities. For me, this begins with shedding the white coat, physically and metaphorically, reclaiming my first name, heading out of the space where I feel most powerful, and meeting my patients and colleagues wherever they are. The act of banishing the armor that so frequently separates us, the omnipotent healers, from them, the subjects, our patients, is critical to establishing a foundation on which true connection and trust is built. So what does this mean? First, quite literally, the home visit. It's a key part of our care model. Our interdisciplinary teams, made up of physicians, advanced practice clinicians, nurses, behavioral health specialists, community health partners, outreach specialists, all of us alike see members in their homes, in addition to virtually and in our neighborhood hubs. And the home visiting ritual is sacred. We schedule appointments for times that we're certain will work for the patient. We invest in the travel time. We knock on the door, we listen for footsteps, feeling that rush of anxiety and expectation as we wait to be invited inside. When we cross the threshold, our eyes adjust to the light, our noses to the smells, our bodies to the spaces we're instructed to sit. For a minute, we are disoriented, uncomfortable, apprehensive even. We're visitors, and we must earn the right to be invited back inside. I found this dynamic to be profound in helping to level out the power differential that is inevitable in the relationship between healthcare providers and patients, and in making both more receptive to authentic human connection. Alongside this, we seek to tackle the deep and systemic power inequalities that are ubiquitous within healthcare itself. The most obvious is reflected in the traditional medical hierarchy, which structurally places the physician at the top of the ladder and the medical assistant at the bottom. The more subtle are tied to the dynamics of power and privilege that pervade our society as a whole, and which fall across domains of race, ethnicity, age, gender, educational background, country of origin, sexual orientation, and so many more. Thus, in reality, it's the middle-aged white male doctor at the top of the ladder and the Latina medical assistant at the bottom. If unchecked, the net result poses an existential threat to attempts to build accountable, effective, and trusting care delivery teams, because we create a system in which some voices are silenced and others are amplified, irrespective of the value of each individual. We have the best chance of success instead when every member of the care team has a seat at the table, is empowered to share their perspective, and has the tools necessary to nurture and sustain trusted relationships with patients. So how do we do this? We're learning. We've started with a few tenets: interdisciplinary protected onboarding, which includes personal storytelling, while we encourage everyone to share their narrative, their human story with their colleagues. First names for everyone, no white coats, no doctor's offices, no special perks. Interdisciplinary teams spend time together, huddle every morning, listen and learn each other's strengths and preferences, building trust amongst each other so that they can effectively collaborate and hold each other accountable. It's complicated. We forced ourselves to confront all the isms and the tensions that pervade our society, to call people into a space where we can own our respective privilege and build empathy for the marginalization of others. It is messy, hard work, but it is vital, and it seems to be working. The second is that we invest in building trustworthy systems. And for so long in healthcare, we've invested almost exclusively in systems and tools that reinforce the lazy proxies for trust. Billions of dollars spent on software upgrades for technology that enables us to better capture the revenue that makes us feel successful. Workflows to more efficiently move people out of emergency departments and into hospital beds and back out again. Automated phone answering machines, and then. All of these are important, absolutely. I'm not so naive as to believe that operational efficiency and revenue optimization are not critically important to organizational viability. However, we must equally prioritize investing in systems that promote trustworthiness, which enable care teams to keep their promises, to be accountable to each other and to our patients, to do what we said we would, even when it's seemingly inconsequential, calling someone to follow up or to check in, to provide updates, ensuring that the loop is closed when a referral is made. So we at Cityblock are focusing on building technology that enhances care team collaboration, reinforces accountability, focuses in on task management and prioritization, which facilitates asynchronous communication between patients and care team members in ways that are comfortable and embedded within their day-to-day lives. The third is that we have to build business models that scale and offer dignity. When we value things, we don't rely on the fickle generosity of others to fund them. When we value things, we don't ignore sustainability and long-term viability. Yet this is precisely how we frequently approach funding healthcare for marginalized and low-income communities. Through philanthropic dollars, tiny pockets of leftover resources in community benefit investment funds as byproducts of research grants, we scrape together resources for pilot programs and yet fail to dignify them and the communities they impact with recurring revenue streams. We spend $1 trillion of taxpayers' money on healthcare every year, And yet we have not created a sustainable business case for investing in longitudinal trusted relationships between the patients and the families who those dollars are intended to improve. Part of creating radical change is aligning incentive structures with the types of care models and interventions that represent true innovation, disruption, and which can scale. For me, this has meant intentionally stepping into the world of a for-profit venture-backed company. I find it both amusing and actually perfectly apt that my first ever job in a tax-paying entity would be at a company that I co-founded, whose mission is to transform healthcare for marginalized and underserved communities. What a beautifully American paradox. And yet I do believe that the discipline, the focus, and the profit imperative in this space at this time for this work is the most direct and impactful way to dignify the patients whom we serve with a care experience that is intended to last and to persist. And finally, we have to talk about and ask about and measure trust. This is where I feel most fraudulent, if I'm honest. I have to admit I don't have a solution here yet. But I believe that we must figure out how to systematically measure our patients' trust in us as individuals and in the systems that we are part of. We have to start by asking our patients what trust means to them. We have to listen intently to their answers. We have to invite them to join us as we lean into the messy, complex work of building, testing, and validating measures to track trust in our daily work. Then we must hold ourselves, our teams, and organizations accountable to delivering on this. No more lazy proxies, no more inferences. Let's focus on what matters, let's measure it, and let's strive to improve. And so there you have it. Some thoughts for a journey that's still unfolding. Progress notes from couples therapy as I seek to rebuild and reframe our broken relationships as healers and leaders in healthcare. And an invitation to you all to join each other and to commit your respective organizations to align in this work, because only then will we stop the shocking things from happening. Thank you very much.